This was a case we dealt with some time ago. 28-year-old lady fell and injured her right arm, closed fracture of the humerus, no neurovascular deficit, no comorbidities, and so the question was, how do you treat it? Okay, so how many would treat it conservatively? What about plating? Nailing? Anyone for nailing? Not even you, Ajit? So, this was what was done. Initial first couple of days was okay, then she started developing swelling and pain which gradually increased. Okay, she was given oral antibiotics, and by the time she came to us, that was the situation at 2.5 months. Okay, so she had a full-blown abscess, was toxic. Can that noise be stopped at the back, please? Can you stop that? Okay, so this is what it was. So what do you think has happened here? Okay, but anything else? Yeah, so this was, just if you look at the canal size here, okay, just look at the canal size of the distal fragment and look at the size of the nail. So obviously they had reamed it up or done something which ended up, so just infection, you won't get that kind of disastrous situation in 2.5 months.
The nail is quite big enough.
That's what I'm saying, it's a huge nail.
And when it gets jammed in the distal fragment, it causes distraction at the fracture site also.
But that's not the real problem here.
That is not the problem over here, but then this happens many times.
So now what do you do?
Remove everything and tackle the infection, probably some antibiotic spacer or something.
What spacer?
Cement spacer.
No, but how do you stabilize this fracture?
You may stabilize it with a small rush rod or enders or something.
So the problem was, if you look at it very carefully, the entire cortex in the distal part, so the anterior and the lateral cortex have disappeared. Okay, so when we went in, so we first actually just drained the abscess because this patient just landed up in a toxic situation. Hemoglobin was low. We decided to just drain that abscess because it was about to burst, and then we had to plan what to do later. Okay, so we got a CT done which just showed us how the distal part, you can see the entire nail here in the 3D without any bone in between. Okay, and so the question was, how do we stabilize this? You take out, you debride. The question was, what would you use to stabilize it? And finally, what we did when we did the surgery was that you only had a thin shell of the posterior cortex remaining after debridement. The proximal fragment was good, and the entire distal fragment, you can see there's hardly any bone that you can see there. And there was pus all over. I mean, although that was less by this time, but there was still infection. And then we decided to stabilize it with one of the K nails that we had, old ones. What we did was we put it into the lateral pillar deliberately because there was no, you were right into the olecranon fossa there. So we actually put it into the lateral pillar, and then we used this antibiotic coated cement all the way here, which added additional stability and also was this thing for antibiotics. So it's a kind of innovation on the masculine technique, not really a true masculine technique in the sense.
So the proximal part was not coated.
Yeah. So there was some cement, but it was mainly this area that was, because the proximal part was okay.
So there was no infection in proximal.
Not it was basically thermal necrosis which had destroyed the bone, and the proximal part was looking quite good and viable. So, and obviously you have to ream it and clean it up, but that was the situation. So then everything settled, infection settled, CRP, everything settled. Now was the question of how to reconstruct it. Okay, so what we did here was so those were the various options, whether you use a vascularized fibula or a fibula stud graft with a lock plate. So what we decided on was, so once we took everything out, you can see the membrane there, the cement here. So we put this plate anteriorly, and then we added a second plate on the medial side because there was cortex there was no cortex on the lateral side. Fibula stud graft, which we put the screws from anterior to posterior through, and then we bone grafted it with a lot of cancellous graft. Okay, so that was her at 5 weeks. You can see the shoulder is still very stiff. So was the elbow stiff. This is at 4 months, she's getting back some motion. This is at 10 months. Now you can see how everything is healing up nicely. This is at 16 months. She's got back a fairly good range of motion by now. And this is 2 years. And the final follow-up at 5 years, 7 months post-op. So managed to maintain that without any recurrence of the infection. That's something you need to watch out for in these cases where you have to decide whether you take out the implants or not. We decided not to, but sometimes it's sensible to take out these implants because you might get recurrence of that infection with the plate there. So I think the take home here is that remember that first, that conservative treatment is still an option for humeral shaft fractures. Okay, so and if you are deciding on plating or this thing, I think generally for the simple fractures, plating with compression is still the preferred mode of treatment. Watch out for the medullary canal because some of our patients really have such thin medullary canals that putting a nail in can be a real disaster, as it was in this case. This is an extreme of it, but we see a lot of other problems with it. We've seen shattering of the bone, etc. And remember that complications of surgery are worse than that with conservative treatment. So at least if you give them conservative treatment, it's a lesser problem reconstructing it later than if you end up with a disaster after surgery. Thank you.
John, one point.
Yeah, sure.
Was the fracture opened initially?
No, it was a closed fracture. Closed fracture.
No, the surprising thing is, if it is pure thermal necrosis, you don't get a fulminant infection like
But
this.
there was infection also, so it was a combination. So,
Because of the thermal necrosis, that necrosis is issue.
So,
And probably one point is that many times our rivers are not that much sharp and that creates more heat.
yeah, and probably the amount of reaming, if you look at the size of the canal and the nail, there's no cortex left at the end of it. Okay, so, thank you.
Thank you, sir.
The different ages, age-based discussion and management. Dr. Vikas Gupta, please.
So good morning friends, it's like a homecoming and I would like to thank foremost Boacon, especially Dr. John Shamshul Huda for inviting me. So I'm going to speak on genu valgum. I think you all know it's the commonest angular alignment which we all see in different age groups and at times is very confusing how to manage. The management is dictated not only by the underlying pathology and severity but also by the age and the presence of open physis. So I have nothing to disclose. Now when you see children in the similar age group with these kind of the intervallar distance and alignment, you are confused. Is it physiological alignment, which we say is a knock knee, or is it pathological alignment or malalignment, which we say genu valgum deformity or simply genu valgum? So to know this, you must understand the tibiofemoral angle progression graph, which was given by Salinas and Benka. A child is born with a pronounced varus, which now overcorrects to pronounced valgus around the age of 4 years. And by the time of 7 or 8 years, the child develops the adult pattern of tibiofemoral angle. So to understand more, if we draw the mean of the tibiofemoral angle and intermallar distance and draw two standard deviations, we will see most of the children will fall within this age group. So a knock-knee deformity, or we say simple knock-knee in a child less than 7 to 10 years can be safely ignored or basically needs observation if it is of normal stature, symmetrical deformity or alignment, and a genu-valgum is of less than 15 degrees and intermallar distance varying from 8 to 10 centimeter. However, having said this, a child more than 10 with intermallar distance of more than 10 and a tibiofemoral angle of more than 15 definitely needs further investigations. We will come to that. So this child, when followed on timeline, found to have normal alignment by the age of 10 years. So what about this child with an intermallar distance of 18 centimeter and asymmetrical deformity, when was investigated, found to have active rickets with low vitamin D and was medically managed, and within 3 months he had a normal radiological resolution along with a biochemical resolution. But at 6 months, deformity still persisted with deranged mechanical axis. Now what to do? We'll come to that. So let us see a few case examples. This young girl, 6-year-old girl, presented with a genu-valgum deformity of around 15 centimeter, along with came with a limp, lethargy and poor appetite. And on detailed examination, one could see that she had stigmata of rickets, active rickets with low vitamin D and raised ALP. So diagnosis of genu-valgum secondary to vitamin D deficiency rickets was made. So the question is, should we correct the deformity or you should correct the bone mineral disorder first? So correcting bone mineral disorder or good metabolic control is essential, paramount to halt further progression of the deformity, and some of the milder deformities do resolve with good medical control, and good medical control favors adequate fixation as was also highlighted in this article. So what she received was a STOS therapy, which is our preference, a single shot of 6 lakhs of units of vitamin D along with supplemental calcium and vitamin D. And follow-up disease assessment is done biochemically and radiographically at 3 weekly for first 2 months, then at 3 monthly. And deformity assessment is done by measuring intermallar distance as well as scanogram after the control of the underlying pathology. So after 3 months, we could see that she had complete radiological resolution and vitamin D was normalized. But when she was seen at 6 months and 6 years and 6 months, the deformity was still there, and she was advised some kind of intervention. But lost to follow-up, she presented again at 8 years with worsening, or I would say persistent deformity, with a severe genu-valgum deformity. Now, how to define the severity of the genu-valgum? By this mechanical axis station. If it lies in the medial 1/3 of the lateral tibial plateau, it is called as mild. If it is middle 1/3, we say it's a moderate genu-valgum deformity. And if it is lateral 1/3 and beyond, we say it's a severe genu-valgum deformity. So one can see she had severe genu-valgum deformity, though her main concern was cosmetic with no functional complaints. So questions are, should you leave it alone or should you go some kind of intervention like growth modulation or osteotomy? Now, if you leave it alone, deformity is likely to worsen and there is no known operative treatment which can restore her alignment. If you go for osteotomy, we all know that it has its own consequences. So, what is the best thing? A growth modulation, which she underwent. Now, let us see some of these questions. Timing. Is it important? No, timing is not important because it's a reversible technique and it is not as critical. It's a temporary epiphyseal disease. So, Stevens in his paper has showed done this growth modulation in child as young as 1 year, 7 months. The only prerequisites are angular deformity which needs correction and the presence of open physeal. Which implant? I think the staples are almost out. Those who have used these staples can vouch that it's a rigid implant which can alter the growth permanently, and animal studies have also shown loss of columnar arrangement of chondrocytes with higher rate of mechanical failure. So the main thing is 8 plate or tension band plate, which is relatively safe. The screws can angulate, staples cannot angulate as the deformity is corrected, and the ease of application and simplicity has resulted in widespread use. Tip, tricks and follow-up. I think if you are doing it, you will know it's a simple technique. Avoid the infrapatellar branch of the saphenous nerve, avoid cutting the periosteum. So one of the tips is any structure which can be lifted with a forceps should be cut because periosteum cannot be lifted, and preserve the integrity of periosteum, epiphyseal vessels and the perichondral ring which can lead to physeal bar. Localize the physeals in both frontal and the sagittal plane. It should be well centered, and make sure that you follow the child regularly. So she underwent 8 plate and was followed regularly 3 monthly to look for the mechanical access station. And at the end of 12 months, at the end of 1 year, she had centralized mechanical access, and I could follow her till skeletal maturity, and we could see that there is no there is no complication. So is there any contraindication of severity of the deformity? Definitely no. This is one of my earlier patients, and he had a very severe deformity of around 32 centimeter, and we did this growth modulation, and I could follow him, and at the end of almost like 2 years, he has a good alignment. And so what I want to say, the severity is not a contraindication for growth modulation. Complications, yes, it has some share of problems, I would say, especially if the recurrence occurs in a younger child. So one of the tips is either you go for the repeat surgery or you go for the slipper plate technique. What is slipper plate? You remove the metaphyseal screw and you retain the epiphyseal screw. So once, if there is a relapse, you just reinsert the metaphyseal screw. So you save the money as well as the time. Now this actually monitor the alignment every few months. This has resulted in overcorrection reversal, especially in the COVID time. Like this girl, which had a complete correction, but she failed to turn up, and when she turned up, she had a reversal of the deformity because the growth modulation continues to work till the face is open. But the beauty of this technique is you just reverse the plates, which was done, and she is on the normal course. So last is the hardware failure, which can happen in obese patient. So either you stack the 8 plates or use a solid screws. Now what about these 16-year-old girl? Now they don't only come with a cosmetic concern. Their main concerns are pain, acute-related pain, poor participation in sports, and the gait abnormalities like circumduction gait. Now this paper has excellently shown that these genu-valgum deformities generate abnormal forces and can lead to early arthritic changes. So I say that it's a pre-arthritic deformity which needs to be addressed. So what are the options? Growth modulation is no longer an option, just a 2 minutes. And you go for osteotomy, either acute or gradual correction. And you must do now unlike growth plate, these children require complete assessment, malalignment test to define the cura, the site of the osteotomy. And there are various distal femoral osteotomies described in the literature. What I prefer, which I developed and redefined, is the V osteotomy, which is published in several journals. And this is a small animation how you actually do it. I'm just skipping this. So basically it has 2 limbs, anterior and posterior limbs. The apex lies at the level of the adductor tubercle. So what you do is, once you have done this, you do a gentle valgus threads to break the lateral cortex, and in manual varus test to impact. It's a basically impaction osteotomy. No bone wedges are taken out. So what you do is, you check the alignment with the alignment rod, and you apply the customized L-Butter state. So this was the result and final result. So what about this severe multiplanar deformity? You have shortening, rotation. So what we are now doing is combining with hexapod, software based, combining with Elizero, which can address multiplanar deformities simultaneously. So these are some of the examples. So just take home message is, the natural history of physiological genu-valgum is of spontaneous resolution. So parents must be reassured. Avoid unnecessary tests. The natural history of pathological angular deformity is not benign and is apt to progress, affecting gait, function. The deformities with tibiofemoral angle of more than 15 degrees and a distance of more than 10 centimeters should always be investigated in a child more than 10. The goal of treatment is to centralize mechanical axis, and guided growth rate is a good option in growing children, and realignment of osteotomies are reserved mainly for children near skeletal maturity. Thank you very much.
When you were discussing the various modalities of treatment, in this era, when we still persist with correction of clubfoot by serial plaster correction, in initial stages in younger children, the same pathology which produced genu-valgum can be reversed by serial plaster correction. Could you add to that?
So serial plaster is not advocated. What we generally do in a very young child is differential massage. Because bones are soft, so we advise mothers to do the differential massage so that we can at least mold the minor deformities. Plasters we don't advise.
One question, sir. Sir, how much overcorrection? Where we say ki we remove staples, so many times it's become difficult. Is there any criteria?
Growth modulation.
Yes. So how much growth how much overcorrection, sir?
Thank you, Shashika. He was my postgraduate when I was in surveillance. So basically, the growth overcorrection is mentioned, but if you are monitoring the child regularly, there is no need for overcorrection. So though the chances of relapses are higher in a younger child. But we normally don't do the overcorrection. We make sure that the mechanical axis is centralized and we follow the patient regularly. Thanks.
Okay, thank you very much, sir.
So we always overcorrect. So about 5 degrees, we allow overcorrection 5 degrees before we remove the plate. Because there is always a rebound phenomenon once you remove the plate.
Actually, Vijay, by the time patient comes, there is slightly overcorrection.
That's what I'm saying. We allow overcorrection about 5 degrees and then we remove the plate.
The other thing is we never leave the place more than 2 years. If you leave the place more than 2 years, it automatically causes the growth.
So thank you very much. Our next speaker, may I call upon Dr. B. Shivishankar, our past President, Indian Orthopedic Association, and he'll be talking on entry site problem in femoral nail. We welcome you, sir, please.
Thank you very much. Friends, by the time they set up, I must thank, apart from my own Maharashtra Orthopedic Association conference, the maximum I have been attending has been Boacon. Since 2011, I have been attending regularly, except Boacon. I think Boacon will invite me next year, without forgetting. So, I have been attending all the conference. Gaya was the first in 2011. Yes. Project करेंगे sir? Okay. So I will be just talking about the entry site problem. This was a young lady, a pregnant lady during COVID era. The person who was driving was COVID positive, so I had to wait. Though she was COVID negative, I had to wait for 7 days as per the advice of the physician. And this is the reduction on table. And I wanted to do a femur raise because there was nothing special in this case. So I took an entry like PFN and reamed initially with a 10 millimeter on the left side and then gradually reaming done. But I was unable to pass, after 8 millimeter I was unable to pass the 9 millimeter reamer. So what I did was I passed the finger which is 8 millimeter one and I passed the guide wire. Once the guide wire went inside, I could ream it. You can see that the reamer has gone and I have been able to ream up to 10.5. And as she was just 19-year-old, the canal was really tight. But when I started passing the nail started hitting the posterior cortex totally. And I was, since it was not advancing further, then I realized that my entry problem, I had taken the entry not posteriorly, it was in the center like a regular PFN I had taken. So what I did was I used a cheese cutter and I nibbled out the posterior part of the bone with this cheese cutter. You can see that eccentrically, since the hole is larger, I could push this instrument and take out the bone from there, and then I was able to pass a 10 millimeter nail and did the locking in this patient. So locking and other thing is not nothing specific here. So just to wanted to show, now we can see that my entry has become much more posterior. The culprit was my entry which was very, very anterior. Why I am showing this is, if the entry is too much anterior, then the hoof stress will be more. So this is the immediate posterior X-ray in that lady, and the entry is medial to the tip of the trochanter or from the piriformis fossa. We see at the junction of posterior to 1/3 with anterior 2/3. So the central entry we take for PFN, because we ream up to 15 or 16 millimeter. Passing a 10 or 11 millimeter nail is not difficult with a center entry with a PFN. If you take the entry too posteriorly, then you might shatter the posterior cortex. If you take the entry too anteriorly, as in my case, what happens is the nail has to go like a S shape. The hoop stress will be very, very high. So this is the normal curvature of the nail, and if you take an anterior entry, the nail has to bend like this and go anteriorly. This is called as hoop stress. We all read in literature saying that the company literature will determine the entry of the nail. Friends, that is very, very wrong. You are the person as a surgeon, you have to decide the entry. If you take the entry wrong, your reduction will be wrong, and always, all the straight nails, everybody agrees that the entry has to be from the piriformis fossa. But for capulomedial nails at PFN, the entry has to be from tip of the trochanter. Everybody tells the same. Here is a case, I was operating, I have taken the entry properly from the tip of the trochanter. I could ream, but when I pass the nail, you can see that I have shattered the medial cortex. So the reason is, whatever the angle we take, that is not proper. So the nail is given 7 or 8 degree bend, but we pass at almost 30 degree from the center. That is the problem. Another case, again my own case, again I have shattered the medial cortex. When we pass from the tip of the trochanter, what happens is the angle it makes is almost 30 degrees. It's not 5 or 7 degrees which the nail is having. That's why the reduction gets lost when we pass the nail. So this is my own way of presenting it. I want the professors here sitting to do some study. This is a Caucasian, white people, Australian and European. This is from one of my WhatsApp friends' picture. If you see, the line is in line with the piriformis fossa, and if you take the tip of the trochanter, there is hardly any difference. It almost goes into the medullary canal. That is an Indian one. If you take the tip of the trochanter entry, you can see that you are not going into the medullary canal, you are going and hitting the medial cortex. The tip of the trochanter in Indians or Asians is very, very off place. So this is what I want to tell. Another thing you can measure is, if you make a line along the lateral cortex in the proximal femur, see the tip of the trochanter, which is far away medially, whereas when you take an Indian or Asian medullary canal, you can see that it's almost in line with the lateral cortex. Our trochanter tip is overhanging, so that's why we should not take. So this is another elderly lady. Again, you can see that if I take a piriformis entry, my nail will go properly inside. If I take the tip of the trochanter entry, I will break the medial cortex. I wanted to make only this point clear with you. This is not given in literature. This is my own version of predicting why I have been advocating to take the piriformis entry for the last 25 years. I have been telling only this. For me, there is only one entry which is in line with the medullary canal, which can be piriformis entry, because piriformis is slightly posterior, but for PFN it is slightly anterior entry. Thank you very much.
Can the entry be the same for a straight nail and a curved nail?
See,
So just explain this to me.
See, if you take the laga dijiye please.
So the problem
Ah.
what happens is,
Ah.
when you take the tip of trochanter entry, by the time you ream, because the bone is soft, your nail gets further lateralized. So the
That is one other thing.
So the
even what I am telling is, even if you are taking proper tip of the trochanter entry also,
No,
in Asian
so-
there will be problem.
So now the recommendation is the medial tip,
Yeah.
not piriformis
Yeah.
fossa, but the medial tip of the
Yes.
trochanter.
See, what I want to convey is, John, the nail is straight in the majority portion.
I
That
understand.
portion has to go in.
No, I understand that, but
Yeah.
you will be sending a wrong message when you say it's always piriformis fossa.
No, no. It's a misnomer. Piriformis is a misnomer for capulomedial nail. It's the center of in the lateral view. Yes.
Shiva, this entry is good for the proximal fractures.
Yes.
For your mid-shaft fractures, when you are doing your PFX, if at all you are doing a PFX, for a mid-shaft or your subtrochanter, below your lesser trochanter, if once you pass the nail, how will the nail accommodate that angle over there with the piriformis fossa entry?
See, you can call it as medial
IT fractures,
fractures.
intertrochanterics, it will cause an automatic normal valgus. But if it is not fractured, that level, if the fracture is below your lesser trochanter, and how will that 6-degree bend in the nail be accommodated over there?
Since you have over-rimmed the proximal canal by up to 15 or 16 millimeter, the bone is soft there. The nail gets automatically adjusted there without any problem.
Yes, bone is soft in older patients, but in younger patients, how will it accommodate?
Yes, it will get accommodated. I have for the last 25 years, I have taken only one entry,
But
and
then
I have never faced any problem with that entry.
Okay, I understand.
Another one question, because I think the design of the nail, I think John sir will agree, all the seniors, that to change the design of the temporal nail only to avoid the pyrethroid disposal, just to avoid the vessels.
Then why don't you give a 90-degree bend and take a side entry? Is it possible to take 90-degree bend and side?
It is hardly 6 degree. It is hardly the angle of the classic AFM is 6 degree angle.
Yeah.
So why you put that? I completely agree with John sir. If you put the same 6 degree angle nail from the pyrethroid disposal, I think you are putting too much stress on the nail.
Yeah, that is the controversy between two. To go much on the medial side, there is a vessel problem. Go on the lateral side, then the abdominal large. That is going on. We are changing entries. So in between we have settled now on the medial side of the.
Naveen, by medial side, if you talk about, people are obviously going to go enter into the primary function, right?
No. But no.
How will you enter from the medial side? You tell me.
See,
One question.
number 4 there. Okay. Number 4 there.
Naveen, the question is, you are putting the 6 degree bend nail from the pyrethroid disposal. The theory of changing the bend, you just listen to it, just one.
Don't take the terminology pyrethroid disposal. He said it was misnomer.
Misnomer. Pyrethroid is posteriorly placed
On the medial aspect
side in the center.
of the greater trochanter, on the medial ridge of the greater trochanter.
If that is recommended for your side aspect, not
It will go on forever, I know. Okay, thank you. You can ask in the coffee break.
Respected chairpersons and dear friends. This was meant to be tips and tricks in nailing as well as plating, but I thought the 8 minutes is too short for both the topics. So I'm just covering only plating here. Slides. Okay. So this is mainly a talk on tips and tricks in plating of the proximal humerus. So basically the tips to success depends on preoperative planning, like in every situation in surgery. What we do intraoperative, how we execute the preoperative planning on table, and of course the rehabilitation. These are the things that determine the outcome or the success of any major procedure. So in the pre-op planning, of course CT scan is mandatory in the most intra-articular fractures, but when you get X-rays, make sure you get two proper views. Okay, so otherwise you may be caught unawares. Here's one case that was thought to be a 2-part fracture, tuberosity avulsion and fixed, but then later it turned out to be that there was a third element also, and that the whole case ended up with poor results. Also get full length views, because you may be caught unawares of a fracture further distal down, so you need to be aware of this. And definitely in 3 and 4 part fractures, get CT scans done like with all other intra-articular fractures. One is to know whether there is a split in the head or not, and second, of course, in elderly fractures, elderly patients, you need to get an idea about the bone stock that there is to determine whether you can fix it or you need to replace it. And of course, the armamentarium is very crucial. Get all the gadgets that you need to achieve proper reduction and stabilization. Okay, and particularly in dislocated fractures or neglected cases, you may need shank spins and so forth to reduce your head. So C-arm positioning is very, very crucial. Many of us keep the C-arm on the head end side, but if you keep it coming from the side, it is quite easy to get both AP and lateral without actually moving the shoulder. And that's the C-arm tilted one way 40 degrees, you can get a proper AP, and the C-arm tilted another 40 degrees the other side, you get almost a true lateral there. So that's without changing the arm position, you can get proper views in this manner. So whether you do a deltoid split or deltopectoral, it depends on your exposure and training. We were taught earlier by all the universal approach, but nowadays it's the deltoid split approach. It's your choice. But for a neglected scenario, a deltopectoral is still a better option. And when there is an anterior dislocation, you may have to tenodesis the bicipital tendon. And in a particularly a hitched posterior dislocation, you may have to osteotomize the lesser fibrosity to achieve reduction and then fix it properly. So these are the things that you need to plan beforehand. And coming to the intraoperative thing, the important thing is, of course, like in any fracture, get your reduction, get your tuberosity held properly with sutures, get the head to be rotated, get your valgus angle, the neck shaft angle corrected, and then put the pieces together like you fit in a jigsaw. So these are the important things in the reduction. How you carry it out, it depends on the fracture pattern and also your understanding of the fracture. So the sutures need to be at the bone and tendon interface, and preferably a double stitch to pull it down with vigor, with strength. So to get the head control, you may have to lever it, you may have to rotate it, you may have to elevate it. So depending on the fracture pattern and the depression that you have, you may need to do all these things. Usually in a two-part fracture, you may have to just lever the fracture back in place, particularly in a dislocated situation. You may have to get the neck shaft angle and sometimes skewer it with a K-wire, thick K-wire, and maintain the position while you plate it. So just make sure that your K-wires are not going to impede your plate placement. So that's important. In 3 and 4 part fractures, you may need to derotate. You will have to derotate the fragment and convert it like a 2-part fracture before you skewer it with K-wires and then put in your plate and fix it. Okay. So you need at least a couple of wires. Sometimes you may need to put a shank spin if it is very osteoporotic to get your rotation and reduction perfectly in place. So you do that, get it in alignment, and then skewer the wires and pass your plate there later. And in a 4-part fracture, you may have to lift up the depressed segment. You may have to elevate it like that. Just showing a brief clip to achieve the reduction. Put in your curved implant, elevate it, and get the alignment restored. Then put a couple of wires to maintain that position, and then pass in your plate. Once you are happy with the reduction both in the AP and lateral views, you go in. The about 135 degrees of neck shaft angle you need to maintain. Okay, so some degree of valgus is preferable to varus reduction, and you have to pay attention to the tuberosity head distance. About 8 millimeters is what is talked about. That's important, otherwise you may have impingement, or if you are too further down, you may not get enough purchase on the tuberosity. So avoid varus at any cost, otherwise the functional outcome will be poor. It may unite, but the functional outcome will be poor. So K-wires I've already mentioned. Check the lateral view, make sure that the reduction is perfect, and get your tuberosities fixed well. The plates can sometimes be used as a reduction tool, not in all situations, particularly in osteoporotic fractures you may have to be careful. You can put a cortical screw like that and pull the shaft towards the head, like so. You can do that and then carry on. Even in an angulated situation you can do that, but you got to be very careful in an osteoporotic situation. You need to be very sure that your proximal screws are in the right place before you actually pull it down to get the reduction like that. If it cuts out, then you are in deep trouble there on cable. So plate position, if you are too proximal, I've already mentioned the impingement. Too distal, then the calcar screw will not come, or the tuberosity fixation may not be adequate. And if you are too anterior, of course, then you can get problems distally. So in deltoid split, what we have found is that the jig comes in the way of where your nerve is passing, the axillary nerve. So we do that without the jig, we pass it like that. This is where the jig actually seats well, seats properly. So you need to make sure that the nerve is not trapped underneath the jig. If you can do it in a large patient, well and good, but generally in our population that's not possible, so we avoid that. Just showing you without the jig, how to pass that, the nerve is there, underneath that it is going, and that's how it is put. And passing the screws, the so-called woodpecker technique, don't drill all across the cartilage. Just one minute, sorry. So, just quickly running through how to get the reduction and fixation. Maintain the reduction, avoid lateral displacement. The medial contact is very, very crucial, so you need to maintain that, and medial continuity is most crucial. So otherwise there will be varus, it topples over and you get a varus outcome. Just quickly rush through, avoid, make sure that the screws are not perforating the cartilage in all directions. In multiple views you get that. Secure the cuff, most important to get a good functional outcome, and take it through a full range of movement there after you've done the fixation. So take home message, pre-op planning is very, very crucial. Keep all the reduction tools at hand, reduce well, and maintain the head distance. Okay, so at the end, I request all to support the Bangalore bid for 2024 IOCON in Bangalore. Thank you very much for your attention.
So no questions, but let me ask you one thing, sir, like what exactly you do at the medial catar side? Does it prognosticate the result of the fracture?
Yeah, I mean, if there is comminution, if there is bone loss, particularly in osteoporotic patients, yes, there are many instances where you have put the fibula strut and fixed it, just to maintain. But if you get the neck shaft angle right, and if there is good contact, you don't need to put a fibula strut. In neglected cases, yes, we have used fibula strut because that gives additional purchase for the screws, just like Dr. John showed in that first case. Yeah.
Thank you very much. So, may I call genital pseudoarthrosis, overcome my failures.
Everybody, I'm going to speak on the congenital pseudoarthrosis tibia. Overcome my failure. Very, very important topics because everybody is dealing with the pseudoarthrosis and dealing with the failure. I'm presenting some of the cases, then I will tell you the details of the literature. First, theory the distraction osteogenesis. This young girl, 1 or 2 surgeries were performed earlier, having pseudoarthrosis of tibia. You can see the scar there. It's about 90-degree angulation is there. It's a very difficult case. So our principle is that first of all, we apply the frame and try to make by Ninja software, we try to make the basic principle of the union is that you make the fragment in the aligned position, otherwise the bone will not be united. So with the help of Ninja procedure, we have corrected, and what we got when we were doing the correction, we got lot of callus formation here because the distraction produces the callus. So it was our surprise to know that during the distraction we got very, very accurate callus, and it was only 23 days. The bone is aligned, and you can find here very, very corrected and during evolution. Lot of callus has been formed. It was very, very surprise to us. So you can see that after removal of the frame, lot of callus is there, and this is after 7-1 follow-on, good alignment of the bone is there. Second case, you can see the pre-operative, and this is the final case there. Second is the bypass osteogenesis. This is another technique. It's a case presented to us with the after failure of the surgery. So it was a non-union pseudoarthrosis tibia. The bone was not uniting. This is a boy. So we have applied the frame. And in this case, what we have done? We have done the bypass surgery. Bypass means we have done the osteotomy here and we were bringing this fragment downward and downward. So we thought we should bypass it. You can see the bone is coming downward. What we have got surprised to know that during the bypass, exuberant callus we have got due to distraction and other things. You can see here exuberant callus is formed there. During the bypass, we have got the exuberant callus, and you see after removal of the frame is there. This is a follow-up of the 1 year follow-up. This is the 2 years after removal of the frame. 5 years follow-up, and in the last 18 years follow-up. Now for the early child he has become a young boy. So you can see that all the things are there. So this is the final X-ray after 18 years. Now we were doing a lot of failures there, so we got such a technique. I'm going to take that technique which is 100% successful. That is cross union tibia fibula osteogenesis with bone grafting. This was a 5-year-old child suffering from congenital osteoporosis, presented with us with a KY fixation. You can see KY was right here, but it's a failure. So first of all, what I say, first of all, you correct the angulation. This is the basic principle, and try to bring the alignment. So we have applied the hinges here, and we have tried to correct the axis. Now we are going to tell about the cross union. Pseudo site exposed by anterolateral incision of tibia. Sclerotic tissue removed from the CPT site. At the same table, tibia and fibula periosteal stripping is done. Tibia bone reduced and hold with a tensioning and fibula. Bone grafting done around tibia and between the tibia. So this is how we do. The tibia is exposed through anterior longitudinal incision, resect circumferential hematoma, and also expose the fibula. Take care of the anterior tibial artery. So we expose the whole thing, remove the periosteum, and we take the bone graft from the iliac crest. Iliac crest outer tables split using thin sharp acetone down to dome. Number 2, decancellation with the curate. We take the cancellous bone. The graft is inserted around the tibia and fibula, between the tibia and fibula. This is the tibia there, so we strip the fibula and we put the graft, whole massive graft in between the tibia and fibula. So you can see that we applied tensioning and fibula, the very good amount of the callus is formed there, and it is after the removal of the frame, one can see that a hard callus is formed between the tibia and fibula. So it's a wonderful technique. You can see that. It's a final photograph. It's a pre-operative and post-operative. Another case, 5-year-old child with a pseudo-process tibia, presented with a pathological fracture and angulation. Photograph. We applied the frame and tried to, you can see the hinges are there, tried to correct the hinges that we make the alignment. Here we have done the same thing. We have put the graft, make the cross union here, and you can see the photo, post-operative X-ray 3 months after that. And this is the 6 months after the Elizera frame. 15 months after the removal of the frame, we have done the 3D study. This is the fibula and this is tibia. The fibula has encroached the, The fibula has enclosed the tibia from surrounding, and the callus formations they covered the tibia. This is the 3D picture, and one can see that 3D CT viewing showing a strong union between the tibia and. Okay, just a minute. So what is pathology? The recent study showed that there is a hyperplasia of the fibroblast with the fibration of the dense fiber tissue. The imaging parameters is present within the periosteum between the fractured bone causes compression, osteolysis and persistent pseudoarthrosis. Total number of cases were 36. From many years conclusion, there was uncertainty over the union of congenital pseudoarthrosis tibia. Since 93, we are treating pseudoarthrosis tibia but with failures. Recently, this new technique has emerged cross union between the tibia and fibula by bone grafting, which has achieved excellent results. It improves success rate towards the 100% in some reports. Thank you very much.
On the posterolateral side, sir, for tibio-fibular synostosis.
No, sir. Because it is the theory that there is a fibroblast in the periosteum. So periosteum, what they do, fibroblast, what they do. So what they do, they kill the osteoblast and osteoclast. They kill the whole bone of the periosteum. So what we do, we remove the whole periosteum, stripping the periosteum, and after that we strip the fibula. And all the soft tissue between the tibia and fibula is removed. We take the graft and we put all these grafts between the tibia and fibula. So actually what मैं ऐसे बोलिए तो fibula ने tibia को पकड़ लिया.
वो सही बात है. Intraosseous membrane पे ना, you keep on the intraosseous membrane that graft.
No, remove everything, sir.
Remove even the intraosseous membrane.
Yeah, everything. Soft tissue, वो fibula की बोल जाके tibia को उसने पकड़ लिया. और जाके तीन थिंग्स है इसमें alignment, remove the periosteum and put the bone graft. One thing I tell you, we are doing the imager off. You can use the external fixator, any fixator. If you follow the things, you can go. A lot of orthopedic surgeons from all over the world, they come to us and they stay with us.
Sir, what is the experience of intramedullary fixation after doing this?
Yes, sir. In one of case, which I have shown you, we have not the intermedullary fixation. So they were refractured. So we put the tensional, anything, put that. Otherwise, we got the history of the 25 years. They got the refracture. So we put that.
Okay, thank you.
So one question.
Hello.
Sir, one
Dr.
question.
Rohan.
Sir, in few cases actually both tibia and fibula will be involved. In few cases there are certain cases at the level of involvement. The level of involvement of tibia and fibula are different. Like tibia is involved at a different level and fibula is involved somewhere around the ankle and all. And after excising both those bones, we sometimes find that there will be some gap in the fibula if the tibia is approximately. So how do you deal with it and what are
This is a very good question. Actually, when we are cutting exposing the bone tibia, we remove everything, we remove the excluded means there is a gap in the tibia. So it is always necessary to cut the fibula at the same level. And we cut the fibula so that when we give the compression, the fibula should not interfere. Because the basic principle of the union in, so what we do, we put the wires and we give such a compression कि धनुष की तरह उसके वायर्स हो जाएं. जब तक हम फिबुला को नहीं काटेंगे सेम लेवल पे, we can't do this.
No sir, question was different. Question was many times this disease is affecting fibula also and both the levels are different.
It's not affecting fibula. Fibula is another thing. we are cutting the fibula. Fibula, it may be involved somewhere else.
Okay, fine. Thank you, sir. Thank
So
you.
one more, Dr. Agarwal, thank you, sir. Dr. Agarwal, basically, what you've done, what we call in old days, teacher, tibia, he was knowing, that was called tibialization of fibula. Basically, we are transferring the load from the fibula to tibia. Can we do this, is it not the same procedure, what we call tibialization of fibula, line? What we need to do that? Cut the fibula proximally and make it unite with the cancerous bone tibia there, and then cut the fibula down and make it unite
You are
down
talking
there.
about Huntington's.
No, I tell you what the problem. At the same level, if we will not cut the fibula, so there will be no osteogenesis. So that is the reason at the same level. And second thing, we are compressing the tibia because we remove lot of sclerosis of the tibia. So for that we cut the segment of the fibula so that the fibula should not interfere the union of the compression of the tibia. So we remove a portion of the fibula. So that is same level because the osteogenesis will come from the fibula. You know, tibia में तो हम लोग लास्ट कितने सालों से बोन ग्राफ्टिंग करते थे, निकालते थे, लेकिन स्टिल दे वर फेल्योर्स कर दिया। तो जब तक हम फिबुला को नहीं काटेंगे, फिबुला की तरफ से सीटी स्कैन, हाँ जी, फिबुला की तरफ से जो ग्राफ्ट जाएगा, ऑस्टियोब्लास्ट will travel through the cancellous graft which we have put from the graft.
Thank you, sir.
Osteoblast तो fibula की तरफ से जाएगा.
Thank you very much, sir. We have a paucity of time, so thank you very much for the lively discussion. May I call upon Dr. Friend? He will be talking on complex femur and its junctional fractures. Dr. Amit Azrauke, please.
He's just correcting it. Femur junctional fractures, now we have come out with the term junctional. It's not it may be a misnomer, but then what we feel is that it is a junction of the middle third and the lower third. Now in femur, the proximal femur has been taken care by Shiva's PFN, and now the mid shaft is also taken care by the AFN or the PFN. How many of you are really doing a normal femur interlock? If you are really doing a normal femur interlock, you have to change a normal antegrade femur interlock. This level is the junction of the middle third and the lower third. While passing an antegrade nail, after you come at this junction, you are entering from a tight canal into a wide medullary space. So like an inverted funnel. This is a normal thinking, it's a normal biomechanic, and you have to understand what will happen if you just pass this and your normal femur interlock which has got 2 and 2 lateromedial lockings in only one plane. So think, this is going to happen. Your nail also many a times does not centralize. How many times does your nail centralize in the distal fragment? The nail has to centralize. If you are doing an antegrade nail, your nail has to centralize in the distal fragment, and the nail has to have multiplanar lockings, an AP locking in the distal plane as well as a lateromedial locking in the distal plane. That should not be a problem. Ultimately, this is what happens, what we call it as autodynamization. This is not autodynamization, this is a failure of your surgery. Don't take it as autodynamization. Look at this. This is one when I was not knowing what to do. Most of you would do an antegrade femur nail in this case, and I have done the same thing. First day it looked nice. Look what has happened. 1 month. What has happened? Here, this is 8 months, and everything has gone messy. And this is the mess that I created. 10 months it had not united. And here at 1 year, patient got convinced by the time it was 2 years, nearly 18 months, that I have to do a second surgery. Oh, you land up in second surgery, third surgery, second surgery, a recon nail, a bone marrow concentrate, everything I did. Unfortunately, it got infected. The whole damn thing got infected, the whole shaft got infected. I had pouring pus, multiple discharging sinusi, and I had to remove everything. The whole thing had infected, beads removed, everything removed, and just put a simple K nail, antibiotic K nail with those beads. And the patient never came back to me unless 1.5 years I had to pull him out of his house and get an X-ray done. It had United at 18 months in that antibiotic nail only. So instead of creating this mess with an antegrade femur nail which is not properly done, we do fast surgeries, but then we don't know what we are doing exactly. So try doing something else. I tried doing this, a distal femur nail. But the distal femur nail also should have proper lockings in the distal canal, a proper entry point. Distal femur nail auto-centralizes in the distal part. It is a thicker nail in the distal part. It has got multi-planar, multi-level, multiple lockings in the distal part. And it should be long enough up till the lesser trochanter locked by an anterior-posterior screw, or if not an additional lateral-medial screw also. This patient united at 8 months. Here again there is a distal femur nail for this junctional fracture. So these are junctional fractures. Even for the lower 4 fractures, I do distal femur nails, but for the junctional fractures now probably the indications for the distal femur nail have increased, and it has to come up, the distal femur nail, here at 6 weeks, 3 months, and this is clinically the patient at 3 months. This is a segmental one. Segmental also, you have got that junctional fracture over there. Why not? Why not enter distally? Here we did a distal femur nail easily, and the nail went up to the lesser trochanter, and this is the post-op. This is 3 months, and by 3 months the patient was sitting and absolutely fine. The only thing in distal femur now fracture is to select the proper implant. At selection of the implant, availability of the implant should be there, and mobilization of the knee day 2 on a CPM machine, otherwise your knee will get stiff. That is a must. This is the nail with multiple lockings, and this is a screw which has got, you look at the change of the pitch. The pitch is good for a good purchase in the near cortex once you put the interlocking screws. Here we put this, and I reduce these on a tibia frame. On a tibia frame, all your femur fractures will get reduced. It's very simple, the shaft and the lower junctional fractures. It's very simple. Otherwise, if you put an antegrade nail, this is going to happen, this transitional movement and instability will cause problems. This is another case, a junctional fracture where we did this. Now with a distal femur fracture, whenever you do a reduction, this reduction tool is so simple. It has a small finger, and with the K-wire you can adjust and manipulate your fracture and get a good reduction. Here we got a reduction and then put these screws, multiple multiplanar locking screws, and at 3 months, and this is at 10 months, good union. The patient can be mobilized. This is a distal load-bearing implant. A distal load-bearing implant is always better than a divided load-bearing implant with an antegrade nail. Here, this was a landmark case which I've done. Many of you might be knowing this. And here, we first thought that articular congruity is very important. Since the patient had a medial condyle lower on, we first fixed the medial condyle lower and then put the distal femur nail. Here, distal femur nail, multiple lockings in the distal fragment, antegrade, the approximately 1 AP locking, and there the DHS. We had thought that it could be a problem, but ultimately at 5 months the patient united, and this is the patient. Patient was put on CPM day 2 of surgery, and this is the full range of movement that the patient has got at 6 months. Here the patient is walking fine and absolutely okay. Now he has come back to me for removal of the implants, but I am advising him, don't remove the implants. Your whole femur is protected, so don't remove the implants unless and until they get infected or any further problem. Summarizing, fractures below the mid shaft need to be tackled well. Distal femur nail with multiplanar lockings is a better implant. Mobilization of the knee and early weight bearing can be started. In porotic bones, beware of porotic bones. You don't depend on the nail, only you may use polar screws to reduce the transitional movement and to reduce the intramedullary space. All antegrade nails, if at all you choose, should be centralized in the distal fragment and should have an AP locking in the distal fragment, AP and lateromedial. Thank you. I can't hear you actually.
Do you mean that you will leave the nail forever?
Leave antegrade forever. Antegrade, I talked about the normal femur interlock. Normal femur interlock with 2 screws up and 2 screws below, I am not at all using nowadays. I use AFN nails, the AFN nails with multiple locks, multiplanar locks in the distal fragment. That is a standard nail which I use for all my femur fractures in the mid shaft level or whenever I am using an antegrade femur nail.
What was the issue in the first case? That simple interlock nail was used, the instability was there, it was not united, then it got infected.
It was a very unstable fracture. You saw that big butterfly and everything. So whenever we tend to go put distal lockings, that distal most locking goes through a very cancerous bone, soft bone. And you saw that that screw also entered the bone. So that locking we are not very happy. You don't lock on the lateral cortex well. So there is a lot of movement, toggling.
You are right. The problem was the instability. Now the later part of the story, you put a K-nail, antibiotic K-nail only.
Yeah.
It has no rotational stability.
No, if you see, if you put no. Naveen, you saw that I have operated in the middle also with an AFN nail. In that AFN nail, the butterfly had united to the distal fragment. And there was infection. There was good enough fibrous tissue there. So there was less movement at the fracture site. If you, in a fresh fracture, if you do with a K-nail, it is not good. But in this cases, it was not to stabilize. It was just to rule out or tackle the infection. Unfortunately, the patient did not come back and the fracture united in the K-nail. It doesn't mean that K-nail is good for all these fractures, though we were doing K-nails. Yeah.
That is why. Okay, can we ask the next speaker?
Thank you.
Dr. Ramchandra sir. Surgical indication and approach. Thoracolumbar fracture management, surgical indication, approach and everything.
Morning everybody. At the outset, I thank the organizers for having invited me here, and an extra bit of gratitude to the people who have managed to prepone my talk, moved it out of the spine session into the trauma session. So just to keep within the limits, I'm speaking on spinal trauma. Ladies and gentlemen, it's a pleasure to be here in Bihar, as always, and it's a matter of immense pride and privilege that I speak here in front of you. I shall be speaking on thoracolumbar fractures, indications and approach. We all face thoracolumbar fractures as our primary christening into spinal trauma, and it's always a pleasure to be speaking about this because I believe that if something has changed in spinal trauma and if something remains constant, it's also management of spinal trauma. I share with you what I have learned over the last 33 years since I qualified to do these fractures on my own. Let's look at a 30-year-old gentleman who's a breadwinner of the family, had a fall from a height and developed a burst fracture of the L1 vertebra with more than 50% canal compromise on the CT scan. This gentleman's MRI looked like this, showing significant fecal compression, also showing a burst fracture with anterior, middle and posterior column involvement. How do we treat such a young person? We need to reduce the deformity, clear the spinal canal, stabilize with minimal levels of fusion, and endorse early rehabilitation. Mind you, in this, the earlier we intervene, the better. However, with a total shutdown, it's ideal to do it not in the middle of the night, but the next day with a prepared operating room. This is what the imaging suggests. All burst fractures are 3-column injuries, anterior, middle and posterior column with a sympathetic break in the posterior column. Treatment is a traditional posterior instrumentation, and this is what we did 33 years back. The Harrington is what we did first, We also used the heart shield for some time, moved to the VSP, which is the variable screw placement from Steffi, then came to the screw rod. And we realized that the screw rod was not a panacea because a lot of them used to break because we didn't address the free bending stretch. We later realized that a minimum of 2 levels above and below were necessary, and posterior indirect ligamentautaxis may not always give us the desired result clinically or radiologically. Hence, we decided that just a short posterior is incomplete mechanically as well as biologically, and there should be some way that the middle column is addressed. Came in the role of anterior decompression. When we are coming in from the front, which was usually a thoracotomy, and that's what I used to do, a transthoracic, transdiaphragmatic retroperitoneal for the thoracolumbar junction, we could get a direct access, put in a strut graft either of the rib which we got during the access or the iliacus depending on the level, or later when we started morselizing the injured thing itself, the vertebrae there, and putting it within a container which is a mesh cage or a titanium cage. This we then moved from back to totally front. We started doing everything from the front, putting the implants as well, getting a good bicortical hold as we showed here, and decided that why go posterior at all. So this is the paradigm shift from the first 1/3 of my practice to the second 1/3 of my practice. Well, we said it reduces the morbidity of a 2-stage procedure, and we also found that these results in our hand, and believe me, there was a bias there because there was literature available, worked well and probably had supposedly better neurological results. Then came the stage where we started combining what we learned in the first 2/3 of our life, where we used to go short posterior and anterior. And how did we do that? We used to do the posterior surgery percute or minimal decompressive, and then do an anterior mini thoracotomy and put in this. This also worked well. How did we then evolve further? We realized that it's the middle column which is crucial, whether it's for mechanics or for neurology. And hence our focus should be on the middle column. The transition from anterior to posterior, back to anterior, and finally combined came in the early 2005 to 2010 era. We realized that all this is being done for the middle column. However, something I realized then, and many of us have still not realized, that neurological recovery is not determined by the surgical intervention and is destined or deemed at the time of primary damage. Hence, never ever promise a neurological recovery. Give them hope, but don't promise it to them. We also wanted to have some idea which are the ones which are easier to treat, A1, A2, A3 from AO, and which are difficult, C1, C2, C3. Basically what happens is if in the AP view there is a shift in the coronal plane, these are in the C category, and these are very difficult, and they will not be easily amenable to a short segment, but will need a much longer segment. So that's what we started doing. There's to almost jack up completely. If you see that, that's almost shut, and just putting a posterior construct has recreated the entire vertebral body. Yes, done early, 48 to 72 hours, but then that has to be recreated. What is easy to reduce is also very easy to collapse. Hence, you have to reconstruct it. We respected the biomechanics, posterior tension band as well as the anterior weight-bearing axis, which is 80% through the anterior and the middle column. You could use whatever you want. You could use the ribs, you could use the iliac crest, you could use a mesh tape with local authorized graft. It's your call. We then moved to percute. We did a lot of these percutes with a combined anterior. A lot of people said you should not do anterior at all, you need an access surgeon, it's morbid, it's more vascular, there's more bleeding, much more time taken, you get a pneumothorax, there'll be hardware prominence. I beg to disagree. Why do I say that? Because if you're a bad surgeon, believe me, even a posterior surgery can get you all that. Look at this. None of those 7 pedicles are in the pedicles where they ought to be. In fact, you will get more blood loss, you will take much more time, you will have a pneumothorax, you surely have hardware, that's what the lady came to me for, and above all, how much have you subjected this woman to? She was a lady. irradiation and your nursing staff and yourself. Hence, what do I do now? And these are the last 5 slides. The protocol today. Vertebrae with rib support up to D10. I do an anterior large footprint cage with a single rod up to D10. Once I come to D11, D12, L1, where there is no rib cage support and there is no posterior ligament complex injury, that means there is no soft tissue injury at the rear. There I would do a short anterior and posterior with the posterior being percute, not an open. However, where there is a posterior ligamentous injury, the posterior is open as well. Look at the transverse connector there. I have also done a decompression and if necessary, some sort of a reconstruction and a grafting posterior as well as anterior. Next, L2-3 upper lumbar without posterior or a PLC, posterior ligamentous complex injury, pure anterior, similar concept, but here it's below. So it's a dual rod construct in front as far as possible, where it's pure anterior. Lumbar spine is far more mobile than thoracic spine. And where it is associated with a PLC, posterior ligament complex injury, it's a posterior open. Look at the transverse connector. And can I have a second more? Followed by a posterior and an anterior. This is, so the final message is which way to go, your way, my way, or the correct way. I have shared with you what I have learned from my mistakes, and as always I have this prayer which says good results will come from experience, experience will only come from bad results. Thank you very much for a patient hearing.
For I would say that within 2 weeks, as the literature says, within 3 weeks, an unstable injury like that, by ligamento-taxis. As far as the neurological recovery is concerned, you very rightly said that neurological recovery is entirely dependent on the time and the thirst of injury and the initial incidence, whatever we do. But if there is a wedging like that and canal compromise, within 2 weeks, if you do a ligamento-taxis, the vertebral height is well restored, and then do a CT. If you find any bony fragment in the canal, then go posteriorly and take out that bony piece. However, as you said rightly, if you do not support the middle column, over the time, there is a collapse entirely due to gravity, and patient usually comes with pain. But of course, the neurological recovery, it has nothing to do with neurological recovery. Regarding putting the cage, fine. If you are very well versed, you can go into here and put, but that becomes a too major surgery for me. If at all, I have to put a cage, I can do it because the bone is very soft at that time in the initial injury. You can put your rods and then you can go from the side as we do in what we call it, the osteotomies for the deformities. From the side, we can go and put a cage, titanium cage or expandable cage as you showed in one of your slides. Well, that's my view. Of course, sometimes really do need to go interior if you see that there is a reduction is not coming, or there is a bony fragment, or it is collapsing, or whatever, and that situation you can definitely go interior. But regarding the neurological results, it is not going to affect much, except the deformity. Thank you.
Thank you, sir. Thank you, sir. Any questions? So the recent literature says that the short segment fixation we can do, and we can put a screw in the diseased vertebrae, in the traumatic vertebrae. If the pedicles are right, I'm good. So would you suggest that, and what are the advantages of that?
So there is a lot of literature stating putting a shorter pedicle screw in the injured vertebra. A lot of literature came from the experience of Ganga Hospital in Coimbatore, and they have a lot of presentations on this. I can stick my neck out and say that I have had no difference as far as my results are concerned with instrumenting the injured vertebra and not instrumenting the injured vertebra. But I would like to just continue with where Sir said 2 points, small points. One, Sir said do a CT scan after 2 weeks to see. Sir, intraoperatively we used to do a contrast. You have iohexol. If you remember what we used to use for myelogram, that same thing can be done intraoperatively and you can pass it and see the flow. We have been doing that in the past when we wanted to take a call whether we need to go anterior or not. And the second point is that we only go anterior to the cord with a separate incision where we think our surgery will be a threat to the dural elements, which means in complete neurology, I don't want to retract the cord at all, so I take a separate thoracotomy. But complete neurology, like in this particular patient which I showed at the beginning, which is an old patient, today if I have to go, sir, I will go posterolateral as suggested by you and put in my cage from there. You're absolutely right. But in complete neurology, where I don't want to manipulate my thecal elements, I go all around. I do not touch the neural elements either by accident or by choice.
Thank you, sir. Thank you very much.
Sir, I call all the faculties on the dais, please, sir, to facilitate them. I will ask Dr. N.K. Singh, sir, to facilitate Dr. B. Shankar, sir. I will ask Dr. Rajiv Anand, sir, to facilitate Dr. M. Ajit Kumar, sir. I will ask Dr. Naveen Thakkar, sir, to facilitate Dr. Arya Agrawal, sir. I ask Dr. N.K. Singh, sir, to facilitate Dr. Amit Ashwar, sir. Now I ask Dr. Rajiv Anand, sir, to facilitate Dr. Ram Chandra, sir. Sir, I ask B. Shankar, sir, to I ask Dr. S.
We had a very informative session today morning on trauma cases. Now we will be starting our CME on pediatric elbow trauma. Pediatric? Yes. As you all know, pediatric elbow is a very common condition which we used to get in our clinical practice. And in our day-to-day practice, we get these cases. A lot of conditions create confusion in clinical decision making what to do. On these topics we are going to discuss. We have eminent faculties from across India. Dr. John Mukhopadhyay sir, He is Director and Chief Operating Surgeon at Paras Hospital, Patna. Sir will be discussing about post-traumatic stiff elbow. Professor Dr. Vikas Gupta sir is from Delhi Safdarjung Hospital. He is Unit Chief and Pediatric Orthopedic Unit. He will be deliberating on neglected Montegia fractures, the management options. Dr. Ravi Chauhan, he is from New Delhi. He is a pediatric orthopedic surgeon and limb reconstruction surgeon working at Sir Gangaram Hospital. He will be discussing about complex supracondylar fractures of elbow. Dr. Vijay Shriram, sir, from Chennai. He is a senior orthopedic consultant working in the field of pediatric orthopedics, spine surgery, arthroplasty and sports injury cases. He will be discussing about lateral condyle fractures and crash lesions. Dr. Ritesh Arvind Pandey, Associate Professor AIIMS Patna, will be discussing about his cases. Dr. Jaswinder, Consultant Pediatric Orthopedic Surgeon from Paras Hospital, Patna, will be discussing about malunited supracondylar fractures, and myself, Additional Professor at IGMS Patna, will be discussing about few cases. We have chairperson, sir, Dr. S. Kamath, Dr. M. Ajit Kumar, sir, and Dr. Upendra Prasad, sir, to chair this session. I hand over this session to them. Please, sir.
Check. Hello. Hello. Good morning, everybody. So this session is CME session. The theme of the session is neglected injury around elbow in children. Our first speaker, Boacon from Delhi. The topic is complex supracondylar fracture. What to do? Silence. Session has started. Please make silence. Please sit down.
Good morning, everyone. Good morning, chairpersons. I am thankful for BOA and John sir and Dr. Samson and Dr. Ritesh Lunu for giving me this chance to speak on this platform. So today's topic of mine that has been given to me is the complex supracondylar fracture with vascular injury. What to do? Well, if we see to the supracondylar fracture, then mainly these are the most common pediatric elbow fractures, second only to the distal radius fractures, and they constitute only about 18% of all pediatric fractures. Most commonly they occur in 5 to 7 age groups, but nowadays this has also been seen in 2 to 3 age groups also. And as per the gender is there is no predilection to any gender. So the most common mechanism, as you all know, is the fall on the outstretched hand, and most commonly they occur at the recreational areas and the homes. Well, if we move to the classification, mainly they are extension type 97 to 99%, and extension type is further classified into modified Gardner classification into 4 types. So if we see this classification and see the words that management, then it seems that close reduction and pinning is the maximum treatment that is available and that should be there. So is this that much easy that there is a 5 to 7 year old child having supracondylar humerus fracture?
Dr. Chauhan, one moment. Can we please have some silence in the hall out of respect for the presenter? They have taken a lot of effort to prepare for the talks and come. Let us have a scientific deliberation during the session. Thank you.
Right. So, having a child of 5 to 7 year old with supracondylar humerus fracture, and we are going to do the close reduction and percutaneous pinning. Is that so simple? Or are there anything else? There are something else into it. So, if that is simple, then child must be walking. But are there any complexities with respect to this fracture that what we are missing? definitely we are missing something. We should not miss that. We should not, we can't afford to miss that. And these complex things includes if supracondylar fracture is associated with the vascular injury. So today's agenda of my talk is how common it is the vascular injury, what are the red flag signs of vascular injury associated with the supracondylar fracture, how to assess the child having the supracondylar fracture with the vascular injury, and is there any requirement of higher center, or what are the various scenarios of vascular injury, how to manage them, and is there any requirement of vascular surgeon or a plastic surgeon? Is vascular exploration really necessary, or if it is, then when? Fate of the upper limb after the vascular surgery. So if we move to the statistics, this was the article in JCOT in 2020 that they took the sample size of about 53,571 pediatric fractures, and in that the incidence of vascular injury was found to be 149. It means 0.3, it's very less. But there are certain other literatures that have reported around 1 to 15% and in some around 4.7%. So roughly we can take that around 5% is the incidence of vascular injury in supracondylar fractures, more common in closed. So if we move to the anatomy and how these neurovascular structures are related to various supracondylar humerus fracture fragments, we see that there is a displacement of distal fragment, and with respect to that there is a displacement of proximal fragment. So in case of the posteromedial displacement of the distal fragment, radial nerve is at risk because of the displacement of distal part of proximal fragment. And when we deal with the posterolateral displacement of distal fragment, then median nerve and brachial artery comes at a fault or comes at a risk just because of the impingement at the distal portion of proximal fragment. Further moving, there can occur entrapment of brachial artery and median nerve at the fracture site. So if after reduction we are seeing that there is a space at the fracture site, or during the reduction we are seeing that there is some soft feeling, then there could be the impingement of neurovascular structure within the fracture site. Supratrochlear artery. Supratrochlear artery is one of that culprit which tethers the brachial artery to the proximal fragment of the supracondylar fracture, and because of this the brachial artery is at risk. The main injury patterns that usually occurs are the spasm, intimal tear, compression of the vessel, and complete transection of the vessel, which is very less. Mainly the two mechanisms are there, mainly spasm is there and intimal tear is there, compression of the vessel is also there. So if we move to the vascular anatomy around the elbow, then collateral circulation. This collateral circulation actually is, this rich collateral circulation actually forms the basis for the pulseless perfused hand. This is our hope, when because of which we can leave the supracondylar fracture as it is, or sometimes we observe it just because of this rich collateral blood circulation. So what are the red flag signs? Type 3 or supracondylar fractures. Whenever we see the type 3 or supracondylar fractures, we must raise our eyebrows that there must be something else. Associated nerve injury, AIN or median nerve. Some of the literature have suggested that usually the nerve, if the nerve injury is there, then definitely vascular injury must be there. But vice versa is not that much correct. If puckered sign is there, then definitely we should suspect the vascular injury. So when a child presented to us with these red flag signs, then it's very necessary that we should assess that child very precisely. So how to assess that child? Neurological assessment is very important in that child. This can be done by motor examination as well as the sensory examination. For sensory examination, child is not that much easy to go, but neurologically we can examine the motor examination to some extent by using the thumbs up test or the OK sign. With the help of thumbs up test, if we ask the child to raise the thumbs up, then radial nerve can be seen, extension of the wrist and the thumb, and the median nerve can be observed by the flexion of the digits second and third. And if the child can make the OK sign, then we can appreciate that ulnar nerve that leads to the abduction of digits 3 and 5 is OK, and anterior interosseous nerve that leads to the flexion of index finger and the thumb DIP is OK. After the neurological assessment, most important thing becomes the vascular assessment. So, color of the skin. When we see that, what about the vascularity? So color of the skin becomes important. It should be pink, it can be pale. Temperature of the skin, either it is warm or cold. Capillary refill time, whether it is more than 3 seconds or less than 3 seconds. Pulse oximetry, this is very important because waveform on the pulse oximetry is very important indicator for the good perfusion. And Doppler, we use in our institute handheld Doppler, which is very important and we find it very useful. So color of the skin and the temperature of the skin, these two are actually subjective. This depends on who is doing and what kind of a temperature it is at the environment is there. So color of the skin and temperature of the skin, they are not that much sensitive as compared to the other three. Capillary refill time, pulse oximetry and Doppler, they are objective in nature. They are more precise as compared to the other two. Moving to the pulse oximetry, it was from the article from Singapore that good waveform is there. Then that is more important in a well perfused hand. It is less. This method is very much sensitive. It is easily available and objectivity is very high. Another one is the handheld Doppler. This documents the pulse. It is non-invasive, rapid, safe, cost-effective, and easily available. I really find it very useful, handheld Doppler and the pulse oximetry in my decision making for the supracondylar fractures. Angiography, but angiography, as it is invasive, have potential risk of causing iatrogenic injury to the artery, contrast allergy, and definitely it delays the time required for the vascular exploration. And advantage is only that it picks up the collateral circulation. But this advantage, because of this advantage, we can't use it. And there are certain studies. One was the management of upper limb arterial. These were the two articles that have suggested that on angiography has no extra benefit over the Doppler. So Doppler is as much effective as the angiography is. So coming to the pediatric supracondylar fracture, if the pulse is present, then definitely if the pulse is present, our way is easy. We need to do the close reduction percutaneous spinning. But what if the pulse is absent? In that case, our hand, if the pulse is absent, it could be non-perfused. What do we mean by non-perfused? Our hand is cold, it can be pale, capillary refill time is more than 3 seconds. So what do we do in that case? We need to, as early as possible, emergency close reduction percutaneous spinning. After the reduction and percutaneous spinning, there can be the two scenarios. There are pulse may come. If it comes, then our work is easy. And pulse may not come, but the hand becomes perfused. There can be another scenario that hand remains pale. In that way, we need to do emergency exploration. Another scenario, in case of the pulse is absent, that hand is perfused. It is warm, pink, capillary refill time less than 3 seconds. So here comes the problem that the management of this perfused hand is controversial. Here lies the problem that we need to observe it or explore it. There is always a debate between the observers and the explorers. There are the two schools of thoughts. Some people prefer the observation, some people prefer the to explore. And mostly these explorers are those who are associated with the vascular surgery departments and as well as the plastic surgery departments. So what do we mean by the well perfused hand? But what parameters I use in my institute, that it should be warm, pink, capillary refill time should be less than 3 seconds, no significant pain to the child, no associated nerve injury, muscle activity should be okay, good waveform on the pulse oximetry and pulse detectable on the handheld Doppler. These parameters are used. So moving to the pink pulseless hand management algorithm. So if we have a pink pulseless hand, means our hand is perfused. In that way, what we do in our institute, that's what I am quoting, that vascular call on standby. We definitely call the vascular that there is a child with a pink pulseless hand, you should be ready if required. So we do the emergency close reduction percutaneous spinning. If the pulse returns, then our work is easy. We discharge the patient after 48 hours of observation. But what if after emergency close reduction percutaneous spinning, pulse not returned? If the pulse not returned, then we need to we usually observe for half an hour to 1 hour, and after repositioning we usually warm the or lower down the temperature of the OT, we warm the limb and observe for 30 minutes to 1 hour. After that observation, we reassess the perfusion along with all parameters, means pulse oximetry, handheld Doppler and everything. So if the limb is well perfused now, then we usually observe it, and if it is poorly perfused, then in that case we go for exploration and ask our vascular or plastic surgery to go for it. So is vascular exploration really required? If it is, then when? A limb which has poorly perfused and remain poorly perfused even after the CRPP. In that case, I'm just winding out the last 2 slides. A limb which was well perfused but becomes poorly perfused after the CRPP. In these 2 scenarios, we need to explore it. So what about the fate of limb after the vascular injury due to ischemia or long-term complications, what we say? Forearm claudication should be there. We need to observe the child for next 1 or 2 years. For BIC, Boacon ischemic contractures, we need to observe the child. These children could have the cold and temperature intolerances. They could have the sensory motor problems. Thank you.
Thank you. Question and answer can be done after 20 minutes time or after discussing the paper. Vijay Sri Ram. Next speaker, Dr. Vijay Sri Ram. He will be talking on lateral condyle fracture greater than 3 weeks old.
Request to all the faculty to please maintain time. You are already late.
I'd like Dr. Shankar. So I'm going to be speaking on lateral condyle fractures of the humerus, more than 3 weeks old. So we just go through a simple, very quick introduction to lateral condyle. Mechanism of injury is avulsion, impaction of the lateral condyle by the head of the radius, or it can be a combination of both. We all know the classification. Salter is type 4, Mills 2 types, the one running through the capitulum and one going into the trochlea. That one will have, the type 2s will have more angulation and translocation. Stages of displacement less than 2 mm, 2 to 4 mm. And in the third fragment, the fragment is displaced, the radiocapillar alignment disturbed and fully rotated. So that's the one which tend to go into delayed union, non-union. Diagnosis is difficult. These fractures are easily missed. That's why you get this delayed union, non-union. They are fractures of the small metaphyseal fragment and they appear in children before the oxygen centers appears. You may have to do an arthrogram, may do an MRI. You have to have a high degree of clinical suspicion. So if you see a child with swelling on the lateral aspect of the elbow, there is tenderness of the lateral condyle, suspect a lateral condyle fracture even if the X-rays don't show it. What is this special radiograph that we all take? This is a child with swelling around the lateral condyle. There is pain, but the AP X-ray is seemingly innocuous, looks normal. And then you do this what is called an internal oblique X-ray and you see the fracture line here. So this was described by Dr. Song in 2007 and this is something we all do. So if you have a suspicion of lateral condyle, you have to take the internal oblique X-ray. There's a failure to recognize progressive displacement and very often they are confused with the lower humeral physeal separations. So in the separation of the lower physeal humerus, the radiocapsular line is intact, whereas in the lateral condyle it will be disturbed. Management, we all know undisplaced, immobilized, must follow until solid union. Frequent X-rays is important, unlike a supracondylar fracture. 2 to 4 mm displacement, you can do close reduction percutaneous spinning. This is very important. This is the rate of displacement for what we think are type 1 lateral condyle fractures. So there are many articles showing that these fractures tend to displace. There's as high as 8 to 10 displacement within the first week in a cast. So we must X-ray them again in 5 to 7 days. And you have to have internal oblique views every time to see whether there is a separation of the fragment. This is how these fractures get missed and end up in delayed union and non-union by not regular follow-ups. Management greater than 4, this is just to complete it. Open reduction, internal fixation. There are very many ways of doing it. Remember, surgery, if you're doing in an acute case, fragment is what is larger than seen in an X-ray. Also, avoid dissection at the posterior border. That's where the blood supply comes in and you'll end up with AVN. Okay, and this anatomical reduction can be done in up to 3 months after the fracture. So even if you get a delayed one, you can do anatomical reduction. It is possible by doing an open reduction. Going through some examples, this is the fractures minimally displaced in the oblique view. They left it alone, further displacement. Then more than a month later, they came, this is an old X-ray done a long time back. Had an open reduction fixed with these 2 K wires. This is not what I will do now. and then one pin was removed because it backed out, and then you can see 4 months post-op, 5 months post-op, ended up with a non-union. So even after surgery, it ends up with a non-union. So this is not uncommon. So let's see how we go about not doing it. So what is delayed presentation and non-union? Delayed presentation of a lateral condyle fracture is considered to be present 3 to 12 weeks after the initial injury. Non-union can present either as a pseudoarthrosis between the distal humerus and the fractured fragment, or no bony union greater than 3 months after the injury. So between 12 weeks, 3 months, that's your differentiation. What are the clinical features? You can have a cubitus valgus, you can have proximal migration of the distal fragment, you can have a decreased range of movement, you can have valgus instability of the elbow, and in the very late cases, you can have a tardy ulnar nerve palsy. That's the mean interval is about 20 odd years. Painful non-union with a gross, when do we treat? Painful non-union with a gross deformity, goal is to achieve metaphyseal union without worrying about the articular integrity. Painless long-standing deformities like valgus with or without a tardy ulnar palsy, you correct the deformity with ulnar nerve transposition if necessary, usually without attempting to unite the non-union. You can have loss of elbow motion if union of the fragment is attempted. This is something you have to warn all the patients, because very many of them move the elbow through the non-union. So if you're going to fix it, you're going to lose motion. Even in painless non-unions though, osteosynthesis is worth it to ensure growth of the condyle in the young children. Role of an arthrogram. Okay, the distal humerus is very cartilaginous in young children. Arthrogram can be used to either help delineate the fracture for more accurate diagnosis or aid with fracture reduction easily. What you're looking for is the articular surface once you fix it back. So this is very useful when you're doing close reduction percutaneous spinning, even if you're doing in a delayed case. So this was a delayed case. We just fixed it percutaneously, did an arthrogram to make sure that the articular surface is intact. Go through some examples. There's a 5-year-old, 6-month-old child came with this injury, 5.5-year-old child, gross swelling around the lateral side, was put in a plaster. They thought it was a type 1, and that's what happens 3 weeks later. Ended up with a delayed union. I did a simple open reduction, compressed it, put divergent wires, and then ended up with good healing. So this is a case where I did an open reduction and just not a percutaneous one. This is a 4-year-old child, again had the swelling around the lateral side, pain was missed. This was 1 month later, this was 2 months later, this was 2 years later. This is how the child presented to me. And in these kind of cases, what I do is, I interpose with a tricortical graft, compress it with a screw. I do not attempt anatomic reduction. If there is no great deformity, I just want to get the non-union fixed and stabilize the lateral side. And that was the follow-up where it showed 5 months post-op, 14 months post-op, shows good union and a reasonably good range of mobility. This was a 3-year-old child, very common. You see this type 3, at least from our parts of the world. They have native treatment done, complete type 3 fracture, and that's what happened 4 months later. And it was completely rotated one, where I have no idea. I took down the whole thing 6 months later. This was the picture pre-op. I took this whole thing down, flipped it around. This was a bit of an anatomic, bit of a fixation, open reduction, bone grafting, and that was 6 months post-op. Ended up with healing, little bit of valgus, but it was too much to do, so I didn't correct the deformity. But the range of movement was fairly okay. This is a 3.5-year-old child, came with this type 3 fracture. You can see the valgus deformity on the left side. This is a delayed union, again fixed with bone grafting. I didn't elect to correct the deformity. I just fixed it with the tricortical graft, screw, and then ended up healing. And you can see that it's sort of stabilized and the valgus is actually gone. It was more of an instability and is now reasonably in alignment. And the range of movement is good. So how do we treat them? In situ fixation with bone grafting of the metaphyseal gap, open reduction, but if you do an open reduction, expect stiffness, and you can sometimes get avian if you start dissecting posteriorly. Corrective osteotomy if the fragment has migrated proximally. So there have been studies on open reduction versus in situ fixation of the neglected lateral condyle fractures, and this was, what they found was union was better in the anatomical group. That is understandable. But complications are higher in the open reduction group, and functional results and the range of motion is much better in the in situ group. So this is what I do. I do not do an open reduction to achieve anatomical results. This is a slightly different case. This is a child with a posterior lateral dislocation, posterior medial dislocation of the elbow, which is rare in children, and had a lateral condyle fracture. This is quite a rare case. This is reported. And then they did a good job. They reduced the elbow, but they didn't fix the lateral condyle. Came 2 months later with this non-union. I did a simple in situ fixation, and then it all healed well. In conclusion, delayed unions are treated with a close reduction and K-bar screw fixation if the fragment is not displaced. Bone grafting is a must when there is a considerable gap. Arthrograms are very useful and close treatment is done. Open reduction is necessary when there is displacement. Articular congruity is a must. This is more for the ones where you get within 3 weeks to 3 months rather than the ones which are delayed, that is more than non-unions which are more than 3 months. Non-unions are treated generally if they are symptomatic, but remember it is worthwhile to treat these non-unions to ensure growth of the lateral condyle. Thank you very much.
Thank you, Vijay. Thank you for that, Mukhopadhyaya, to speak on post-traumatic stiff elbow.
Stiff elbow, and these are not uncommon problems after trauma of the elbow. They cause significant disability. Remember, vigorous physiotherapy often exacerbates the heterotopic ossification or stiffness, and if you are planning surgery, you really need to plan them carefully. You need to first assess if the causes are extrinsic, with things like heterotopic ossification, the capsule, or skin or subcutaneous tissue, or if it is an intra-articular problem which is causing the stiffness. So you need to deal with these. So we'll start with a case. This is a 16-year-old boy. He had an elbow injury a year before. This was reduced, and the post-reduction, I have all the X-rays but I haven't brought them along. The post-reduction X-ray was not bad, but I think he developed stiffness for which he was given vigorous physiotherapy. And he came to us at 1 year, and that was the situation. So he had got a complete heterotopic ossification with sort of the bony bridge extending from the ulnar to the humerus with no movement at the elbow at all. So I think in these situations it's worth getting a CT to assess where the bony bridge is. And if you look at it, the radial side is okay. It's all on the ulnar side. So this was the situation. We decided to approach it medially from the ulnar side. You mobilize the ulnar nerve, and then we took the entire medial mass of muscle anteriorly. Okay, so that gave us exposure right to the front of the elbow. As you can see, that entire myositis mass that you can see, the heterotopic mass extending from the ulnar onto the humerus. So you delineate that carefully, getting all the soft tissue off, and then you can carefully take out the entire myositis mass, the heterotopic mass clearly. And that the job doesn't stop there, because by now it's not just the bone that is causing the problem. There are a lot of adhesions within the joint, and you need to release all these adhesions. So you can see you're carefully releasing the adhesion in the elbow joint, between that and the olecranon. So you have to release all these adhesions till you are able to get almost a full range of motion on the table. Okay, so this is important. For removing the bone, you also need to release the adhesions within the elbow. This is the post-op. It's kept in a slab, and then we start early motion. And this was at a year. He had regained quite a good motion without any recurrence of the heterotopic ossification. Slightly different case. This is an intra-articular problem with a 6-year-old child presenting 5 months after injury, again with a complete stiff elbow. Here the diagnosis itself is a problem, because if you look at it very carefully, the entire humerus with the capitellum and the lateral condyle has displaced anteriorly, while the trochlea has remained almost in the olecranon here. So you can see that this is the entire shaft with the capitellum, etc., which has gone off anteriorly. So here, because it's a 6-year-old child, you don't want to do an olecranon osteotomy, but you need to get a really good exposure to be able to deal with it. So what we did was actually used a trap approach, which is from the adult surgery that we do. And you can see how we peeled off this entire triceps along with the aponeurosis and the anconeus of the proximal ulna. So that's the cartilaginous part of the proximal ulna there. Okay, so the entire thing is mobilized now, and now you can see how the medial part is still in the region of the olecranon, Well, the lateral part along with the shaft has gone anteriorly. So what we do is expose it completely. We osteotomize this here, and you can see the cartilage is still looking nice and glistening. So we do an osteotomy here. We get this piece back into position. We reduce it accurately so that you don't have any intra-articular steps, and then you complete the fixation, stitch back the aponeurosis, and in this case we did put a transarticular wire for 3 weeks because we didn't want this to dislocate again. After 3 weeks, this transarticular wire is removed and the elbow is put into flexion, kept for another couple of weeks and then mobilized. And this is her at 4 months post-op. You can see she's got a reasonable motion. One of the K-wires migrated, we had to take it out. So that was at 28 months post-op. You can see now she's got a fairly good range of motion, and we have a 5-year follow-up on her. You can see how the elbow joint is maintained quite well with a good range of motion from a situation which was really difficult. So how do we approach these? I think first is the decision making, then you have to decide what approach to use. So there are various approaches you can use. You can use a dual incision, you can use a single medial or lateral approach, you can use the posterior trap, and in the older child you can even use the olecranon osteotomy. So this depends on the pathology. If there is a significantly stiff elbow without any previous surgery, we tend to use the dual incision. The medial incision is along the ulnar nerve, and the lateral incision is like in the Cocker's approach plane. And the first thing we always do is release the medial ulnar nerve and be prepared to transpose the nerve, because this is important in the really stiff elbow, because early on when we didn't do this, post-operatively some of them developed ulnar nerve problems. So we do this as a routine in the really stiff elbows. First stage, mobilize the ulnar nerve, release it and prepare for transposition. Then we go to the lateral side. You gradually release the muscles anteriorly. You go across from the capitulum onto the radial head. So now you can see that all. Release them posteriorly also the muscles till you get to the joint, and then you have to release all the adhesions within the joint, starting from the radiocapitellar joint, extending to the humero-ulnar joint. You release all the fibrous tissue that is there. You need to excise that very carefully with the knife, not to damage the articular surface. Okay, so that's it. So you're getting the release as you go on, and then you have to keep going till you get a full release of the joint and are able to get almost a full range of motion. So again you can see we are releasing now the anterior capsule. So you have to do this very carefully because you have all the neurovascular structures anterior to it. But sometimes before you do that you cannot get full extension. So carefully release all the anterior capsules. So if you do an anterior capsulectomy along with all your releases to get full extension, and hopefully at the end of it you are able to get full flexion, full extension. Post-operatively, initially we put them in an extension slab and start early motion. Once the sutures are removed, they are given this dynamic brace where they can put it in flexion and extension and lock it after they've done the exercise. And that is our standard treatment for many of these stiff elbows. So take home, I think you really need to assess this carefully, rule out infection, especially if they've been operated on before, decide whether the contractures are extrinsic or intrinsic, look at joint congruity because that's important, and then plan your treatment carefully so that you can get a good range of motion, and try to get the best range of motion possible at surgery so that you'll be able to regain this range of motion later. Thank you.
Vikas Gupta to talk on neglected montegia, observe or to operate.
Before I start, I want to have a show of hands. How many of you have missed montegia? Yeah, most of them. So I think this talk will be useful. So should you observe or should you operate? So let's see from this presentation. Now, let me quote what Sir Watson Jones said in 1943 about montegia fracture dislocation. No fracture presents with so many problems and no injury beset with greater difficulty. I think his words still hold true. So this was described by long back by Montegia, an Italian surgeon, in 2 cases of neglected injury, but was elaborated by Bardo, a Uruguayan, and he coined the term Montegia lesion to describe Montegia fracture dislocation. That all fractures of the ulna, irrespective of their location, that are associated with dislocation of the radial head in various directions, and then he subclassified as type 1, type 2, type 3 and type 4, which we all know. So what is neglected Montegia? By definition, any traumatic radiocapsular dislocation that remains unreduced for more than 4 weeks or remains untreated is termed as neglected Montegia, because that cannot be reduced by closed means. Now estimated 33% of the acute Montegia injuries are missed according to Western literature, even by skilled radiologists and skilled surgeons, especially when the ulnar injury is very subtle or there is a plastic deformation, or by the surgeon who is ignorant about this entity of Montegia, like this one who was treating this child as a fractured shaft ulna, which ultimately led to radiocapsular dislocation. So diagnosis, the one should remember that any disruption of the ulna or change in the ulnar bowing should alert the surgeon to look for the radial head dislocation, that is loss of radiocapsular contact, by looking at what is known as radiocapsular line or Storen's line, which is a line drawn along the radial neck, passes through the middle third of the capitulum in any degree of elbow flexion. But remember the catch, the rider, in a true lateral view. Remember, it should not be oblique view. A true lateral view is when beam is centered on the elbow, epicondyles are superimposed, and there is a good teardrop appearance by coronoid and oblique fossa. The change in the ulnar bowing is judged by a very novel sign or line which is known as Mubarak's line. In a normal forearm, dorsal border of the ulna is almost straight from auricular to distal metaphysis. But any plastic deformation or malunion will cause it to deviate for more than 1 millimeter, which is known as ulnar bow sign, and it is a diagnostic of radial head dislocation and diagnostic in Montegia, neglected Montegia. So how do you manage a neglected Montegia lesion? Should you observe? Now before you observe, you must know the natural history. It is not benign. In long term, the patients have significant morbidity. They may do well in short term. You will see that they have developing progressive cubitus valgus, restricted motion of the flexion, pain and popping sensation in the elbow, and almost 10% of the children present with late, either posterior introitious or tardy ulnar palsy. So the goal is operated as soon as the missed lesion is identified. However, some surgeons try to avoid operating in a fracture which is more than 3 years old, long duration injury, and in an older child more than 12, because of high chances of unsuccessful results like recurrent subluxation or dislocation of the radial head, because of the dysplastic changes in the radial head, in the capitulum, and loss of the radial fossa. So let's go step by step. What should be the approach in managing this? The common approaches which are used are cockers and voids, which are distally extendable to the ulnar border. And removal of the dense fibrous capsular tissue is paramount to achieve the stability of the radiocapitular joint, as well as removing the remnants of the annular ligament. Now, the ulnar deformity correction, remember this point, is the essential and key part to address the pathoanatomy. And the ulnar osteotomies are various types, this type transverse or oblique, corrective or overcorrective. It could be at the site of the deformity, that is cora, or at the proximal metaphysis. So what is deformed? If the osteotomy is done at the cora, that is at the metadiaphysial or diaphysial, you need less ulnar angulation. However, there are more chances of non-union and you may require bone grafting. However, osteotomy done at the proximal metaphysis achieves better healing, correction due to greater reduction forces. However, you need over-angulation or over-correction of the ulna, which is the preferred these days. So degree of angular correction through the ulnar osteotomy can be corrective. Just you are restoring the posterior cortical line. But preferably it should be over-corrective. You are reversing the original deformity, which achieves better correction. And the amount of ulnar angulation and elongation is judged intraoperatively. You see the stability of the radiocapitular joint during the open reduction. Now, ulnar osteotomy fixation in the past, either some of the surgeons are not fixing at all, relying on the periosteal stability, which was mentioned in the books, or with wires or nails, which provide relative stability, or even sometimes the external fixator. Some of the litho surgeons are using the external fixators, which has its own pluses as well as minuses. However, the preferred technique, the preferred implant is a plate which provides rigid fixation. It can be bent at the desired correction angle and allows early mobilization. The grafting is dictated by the gap which is created. Usually, if a gap is more than 10 millimeter, one can go for the bone grafting. In theory, annular ligament reconstruction may give some stability, and if it is intact, it gives some amount of stability and it can be reconstituted. However, the retrospective studies have shown that comparing ulnar osteotomy and ulnar ligament reconstruction versus plain ulnar osteotomy, there are no functional differences. Combined group has higher complication rates such as notching, loosening of this ligament and loss of pronation. So the conclusion is there are no significant benefit of annular ligament reconstruction. Stable and successful reduction depends on the ulnar osteotomy. And in case the ulnar head is unstable, even in pronation, adjust the ulnar osteotomy, angulation and the length. So transcapular pinning has its own downside. However, if your osteotomy and angulation is correct, you don't need transcapular pinning. However, having said this, if there is some concern about the stability, one can go for a thicker pin which can avoid the pin breakage. However, the elbow stiffness concern is always there. Radial osteotomy and dissection of the radial head have been described in the literature, which I don't propagate, and because radial head dissection results in poor outcome in children like valgus instability, proximal migration radius and chronic wrist pain. So let us see some of these examples. This young girl presented 6 months after the injury with restricted motion and developing increasing valgus on the right side, and one can see clearly the radiocapital line is displaced with the ulnar bow side. So she underwent open reduction with overcorrective ulnar osteotomy and plate fixation. So that's the result after 1 year, and she has good motion, regained all the almost pronation and supination. What about this child? He had an injury 1 year back and he presented like this, and my resident continued to treat him like malunion ulna without realizing that this X-ray is not a true lateral view. So this I want to stress, always get a true lateral view. And when we got this true lateral view, we could see the clear extent of the injury with displaced radiocapital line and the ulnar bow sign. And again, he underwent the same procedure. That's a follow-up after 6 months and after a year. But what you can see, there's still loss of pronation. So what I want to stress, the earlier it is done, better are the results. Now, the two questions come to our mind. Is it congenital radial head dislocation? If a girl presents, a child presents like this, but if you get the full length X-ray, you will see that there is an ulnar bowing. And usually congenital radial head presents like a bilateral involvement, usually posterior, with gross limitation of flexion and supination, and along with other associated congenital anomalies like synostosis. And there is excellent criteria given by McFarlane that there is an absence or hyperplastic capitulum with dome-shaped radial head, absent central depression, and marked ulnar bowing. So this girl underwent the same open reduction along with the pinning, and she got the good result. Now the last question which comes to my mind, is it isolated radial head dislocation? Now it's a very rare entity. There is a lack of description in the literature, very rare in children, seen more frequently in adults, especially with complex elbow trauma. And most of the cases, if you see clearly, see the X-ray, there are associated plastic bowing of the ulna. The few papers which are described as this entity are actually Montegia variant, which are associated with laxity and hyperextension of the elbow. So to conclude, the take-home message is, the first and foremost, recognize initial injury and give appropriate treatment, and you can prevent the sequelae. Treating neglected Montegia is much more difficult than treating acute Montegia. Never compromise on the X-rays. Go for good quality X-rays of the elbow and the forearm. Early surgical reduction provides good outcome prior to the onset of chronic pathologic changes, which can result in poor outcome and the early arthritic changes. Radiocapitular reduction, now the concept has changed. Radiocapitular reduction relies mainly on the ulnar bone correction, that is angulation as well as the elongation, both in length and angulation rather than annular ligament reconstruction. So that is the key point in a neglected Montegia. So thank you.
Thank you, Dr. and useful presentation. Now, next speaker is Dr. Jaswinder from Patna. He will be talking on malunited supracondylar fracture management.